Hi, hello.
Thank you.
I know it's been 2 fabulous days, but very long, so probably very tired. So I'm gonna try to make this talk that I'm gonna show you results that you probably have seen, but now I'm gonna focus in women. So people, as we all know, are different, and we wanna prefer different things. So my first question, there is no QR here, just raise your hand if you prefer window or aisle. Because who prefer window? Okay, and who prefer aisle? Okay, so different options. And then in this one, who prefer a fancy steak with French fries or a salad? But there's people that who will like both. Okay. So different options, different desires, different goals, because it depends on everybody. And we want what we really want, and we can choose. And now in HIV treatment, people can choose. And we, as physicians or healthcare providers, we should offer these different options. Sometimes it's not possible because our governments or our companies or our insurance company don't allow us to provide all the options, but there are several options. And what are the future or the new options in terms of delivery treatment, long-acting treatment? You can see there implants, vaginal rings, gastric device. Some of them are in the process of research. Some of them are already in the market, like injectables. So I'm going to focus on injectables in women for treatment HIV. There is a very long pipeline of studies that have been done for several years, but I'm going to choose a few of them. All of them, or all studies, because they're from 2020, not very old, but probably you already have seen the results, but I'm going to focus in the results just for women. So I'm going to start this with Susan Swindles, and one of the great things is these 4 works I selected, the main authors are women. So that's an important thing. So this was published in 2020 in New England. It was the very first publication talking about long-acting. It is called the Atlas study, and there was a second one, is Atlas 2M, that I'm going to talk a little bit about. Long-acting cabotegravir and rilpivirine for maintenance on HIV suppression. It was a phase 3 study, open label, non-inferiority trial, 13 countries, that's very important, but not very different countries. There was no countries in Latin America, few like very global north-oriented mostly. Participants had to have a viral load, undetectable viral load for 6 months, and being on standard treatment, and there they were randomized as 1-on-1 to switch or to continue, and either the ones who want to switch, 1 month every month, or 1 injection of cabotegravir and rilpivirine. And the primary endpoint, as usually, was a proportion of patients with more or with viral load higher than 50 copies at 48 weeks. A little later, there was Atlas 2M, that was the continuation study, those patients that were randomized to start with cabo rilpivirine, they continue, and the ones who were in oral, they changed to, and then they decide if it was every 4 weeks or every 8 weeks. But more or less, the study was the same, and the primary endpoints were the same, viral loads over 50 at 48 weeks. Another study, and I'm going to comment the results then all together, is from Professor Claudia Cortes, also a female. Long-acting cabotegravir and rilpivirine after oral induction for HIV infection. First, it was published at New England at 48 weeks, and then later was published for 96 weeks of follow-up of the FLIR study. So I'm going to give you the results. In the FLIR study, the design was, again, a randomized, open label, phase 3, 11 countries in this case. Virological suppressed patients, they were naive patients. They would start with dolutegravir, abacavir, and 3TC for a while, and then they change after an oral, I forgot the word, OLI. Thank you, orally did for 4 weeks, and then they change cabotegravir, rilpivirine, one group, and the other group keep the treatment, the oral treatment. And the primary endpoint, they show it in the other way, instead of how many patients fail, how many patients were succeed. So here you can compare a little bit Atlas versus FLIR, experience versus naive, but at the end, even not taking into account the difference of the patients, the follow-up was more or less the same, and the outcomes or the primary endpoints they were measuring were the same: 48 weeks, 96 weeks, how many patients were undetectable, and of course, safety were also measured. So 308 patients in the Atlas group, median age of 42 years, 26% were older than 50, and 33%, one-third, were women at birth. On the other side, the FLIR study, a little bit more patients, 50% divided in each group, 34 years, 11% were older than 50, and 22% were women. Not very high numbers, but these were probably the first studies that start having, like in the design, an amount of women. So the virological outcome of Atlas at 48 weeks, 1.6% in the injection sites and 1.0 in the oral have a viral load higher than 40 copies. So they were not undetectable. And that was non-inferiority. And remember that the design of this study was non-inferiority. This is the whole group, women and men all together. The adverse effects, more common in the injection group, of course, because they have the pain and the lesions surrounding the injection, but we already know at this point that they're not very severe. They last few days. And after several injections on time, people start stopping complaining. On the FLIR, virological outcomes after 96 weeks, 3% of the participants in both groups has viral load higher than 50 copies. So again, non-inferiority. So in this way, we know that injectables for this population, naive in one and most exposed in the other, is effective. So here you can see, and always it's easier to see here in the graph on the right side of your screen, that there was no difference, so no inferiority comparing oral current antiretroviral treatment with Cabo and Rilpi long-acting, could be 4 weeks or 8 weeks, depending on the study. But if we go for women specific, and we see the results all in women, 48 weeks, again, I want to mention that Atlas and FLIR were designed with a specific enrollment targets for women. Atlas must have 1 in 4 enrollees were to be women, FLIR 1 in 5, but at the end it was a little bit higher even. 27% and 28% of women were randomized in both studies respectively. The subgroup analysis by sex at birth was pre-planned. So it was not something that we are saying, oh, what happened with the women? Well, let's see later on. No, it was designed to study what happened with women from the beginning. In the pool analysis, they were efficacy, safety, treatment satisfaction, and retention in women in what I'm talking to you. And one of the important things, are there biological difference between the dose or between the PK and PD and the concentrations of cabotegravir and rilpivirine because of women, because of hormone cycles? And there is not. There was no difference, no clinical significant difference in plasma concentration or cabotegravir or rilpivirine in a woman by sex at birth over 48 weeks of follow-up. So that's not an issue, that was not a difference. And then if we go to the pool results, we see in red bars, the virological success at 48 weeks was 92.6 in the cabo-rilpivirine long-acting compared to the current oral treatment, 94.6, so there's no difference if we put all together. So we can see first in the whole universe, men and women, it works, and if we see only for women, virological non-response was infrequent at week 48. 92.6 of women on cabotegravir and rilpivirine achieved virological success. I'm not going into the few women that have viral failure and their mutations about that, because that's another topic, but there were very, very few, and at the end, the results in this is that they were non-inferior. If we go to the safety summary, you can see that there are very, very few, and what is surprised me is that men complains more about pain I don't know why. 82% of men complain of pain of injections, only 66% of women. But at the end, there was no difference. And at the end, there was very few interruptions of the treatment because of adverse effects. Most of them have to do with injection itself. So safety profiles were similar between women, men, and the overall population, with women exhibiting numerical lower adverse effects rates compared with men. But the message is at the end that the adverse effects were very few and minor. So conclusions, monthly cabotegravir rilpivirine was not inferior to daily oral 3 drugs regimen, demonstrated high efficacy in women specifically. Virological failure was very low. Women had lower rates of adverse effects, and rotation rates and treatment satisfaction was very high. I didn't show you that in this study, but I'm going to show you the following, because women like or prefer injections. So another study, again, Dr. Adia Rana, also women, presented last year at CROI, and this is different because this is a very specific population. Even it's a study, and with all the rules and the follow-up of a study, this is people that were not very adherent, that lost to follow-up, and they don't take all the pills. So it's very easy when you choose the perfect population for your study. It's not that easy when you don't choose the perfect population and you want to show that your drug is efficient. This is the latitude study. So there are barriers to adherence, can make difficult the oral treatment. Caborilpivirine was already approved for FDA last year when this was presented, but only for people with undetectable viral load. So long-acting injectables can be an alternative for adherence challenge population. That's this study. What is this study about? So in this case, there were 3 steps. For the first one was people with adherence problem, hepatitis B negative, no INSTI, no drug interactions, or no mutations. And for 24 weeks, they were follow-up with oral treatment and conditional economic incentives. So they take their pills, they intervene in that way. And then they changed to, in the step 2, to oral, keeping the oral treatment that they were at the beginning, or changing to injectables, LA, long-acting cabotegravir rilpivirine. And then they follow up all of them longer with injectables. So the primary endpoint, again, as always, treatment failure, defined as the earliest confirmed virological failure or discontinuation, people that drop the study. And you can see here, female at birth, 30%, transgender spectrum, 5%. And remember that at the very beginning, the first step, people were given oral treatment and they put money on the table to improve their adherence, but not all of them improved their adherence. So there was a percentage, not very high, but there was a number of patients that start injectables being with detectable viral loads, and some of them very high viral loads, not a lot of patients, 8 participants have viral load more than 10,000. And the results, and this is very interesting because this doesn't happen very frequent. They need to stop this study because the superior efficacy of long-acting cabotegravir rilpivirine in secondary outcomes in compare to taking pills. For this population that have problems of adherence, that already have, before starting the study, they have this adherence issue, was better to take long-acting or to inject long-acting. Okay, so the interim data analysis used for long-acting caborilpivirine in patients living with HIV with adherence challenge show fewer regimen failures. So this is superior efficacy, and have fewer safety issues, fewer virological failures, treatment-related failures, and a permanent treatment discontinuation. So this population that is already not approved to use because we're waiting to have undetectable, maybe this is a very good option. Of course, we need to choose very well because of the long tail that happens when people don't show up, but it seems that it can work. And finally, this is the last study, Dr. Cici Kitio, again, another very strong woman. She published Lancet HIV last year, 48 weeks, and now in CROI, a couple of weeks ago, 96 weeks of the CARE study, randomized trial long-acting cabotegravir rilpivirine in Africa. And why in Africa? Because all the previous studies that I mentioned you have some very few participants in Africa, but this one is only in African people. Why? Because the majority of population living in with HIV in Africa are Black African women. So here the percentage of women is higher. There are different subtypes of HIV-1. They have previous non-NNRTIs, very high, and pre-treatment resistant, and the option of measuring viral load is very difficult because of economical issues. So how we can do this in a setting without a lot of virological load measures? Can we do it? Is feasible or not? Again, the efficacy of long-acting cabotegravir, it was demonstrated at week 48. Remember, this is the results of week 96. So this is the study. Again, cabotegravir rilpivirine with an oral lead-in, then changed to injectables every 8 weeks compared to the standard of care, TDF, or plus 3TC or FTC, plus dolutegravir or nevirapine or efavirenz, it depends on what the patient were on. And the main outcome at 96 weeks, undetectability by the FDA snapshot and intention to treat. And the secondary outcomes, viral load higher than 50 copies with a 4% of margin, looking for not inferiority. And the results in this part are the 96 weeks. The other ones we already know. And here, the percentage of women, 57% in one group and 58% in one group. So this study was more focused, not only in women, but have a higher percentage of women. So this study included people from Uganda, Kenya, and South Africa. And the retention rate after 2 years, 96 weeks, was 98% in the long-acting group. That was great, so a lot of adherence. Okay, so did the participant receive the injections when they were supposed to? Because that is one of our biggest concerns. Thank you. So 81% of the patients received all the scheduled injections within 7 days, the protocol definite window, so on time, 81%. 97% of the scheduled injections occurring within the 7 window. So yes, people are coming back to get their injection when they're supposed to get their injection, so it's working. So finally, the outcomes, it was similar. You can see in light blue versus in green. Light blue is the oral treatment. No, the other way around. But you can see there's no difference between the virological success was exactly the same, 96.9 and 97.3. No statistical difference in terms of indetectability. So long-acting cabotegravir and rilpivirine, non-inferior to antiretroviral at week 96 in intention to treat. The sensitivity analysis per protocol confirmed not inferiority. And again, you can see the adverse effects, grade 3 or more than grade 3, were very, very few related to the study drug, but more than the study drug have to do with the injection itself. And if you see the injection site reaction, the smaller table, pain, swelling, nodular erythema, rash, discharge, abscess, very, very few, less than 1% for the more serious adverse effect. So what are the conclusion of this? Switch to long-acting cabotegravir rilpivirine, non-inferior to continue oral antiretroviral at 96 weeks, 2 years, with limited viral load. That's very important because in a many countries of the world, there's very few access to viral load. And also, despite high obesity rates, I didn't show you that table, but that's an issue, and we know or we don't know what happened with high obesity rates if the drugs, if the PK, it's the same. And with prior NNRTI exposure and a prevalence of different viral subtypes from the rest of the world. So it worked, and also was safe and well tolerated. Severe, grade more than grade 3 adverse events were very few, less than 2%. The injection site reactions were mild to moderate. Only 1% discontinued because of that. So 99% of the patients on long-acting rilpivirine injectable expressed their preference of long-acting versus oral treatment. So it works, it's safe, people like it, and people they adjust to the treatment, they come back, they get the injection in a scenario that is more challenging than having a very nice study in the global north. Okay, so finally, all this can work, all this can be great, all this new combination, but there are a lot of barriers of knowledge for physician, for the patients or the user, huge barriers for implementation and health system and price and cost. So if we want to make these drugs available everywhere, 99% of women that were surveyed want that, we need to go through all these very, very big barriers that we are facing. So that's almost my last. Thank you very much. And I have to say that yesterday was my husband's birthday. I was here. It's going to cost me a little bit when coming back, but that's there. Thank you.